I'd like to welcome you all to our community conversation for HealthAdvocateX for the month of July. It is a great pleasure to introduce Dr. Lisa Barlett, who's here to talk today. She is a professor at the University of Wisconsin in Madison, and here to talk about women's health care after the Dobbs decision. So I'll pass it over to Lisa, and thank you for joining us.
Thank you. Thank you, everyone. Thank you so much for having me. It is always good to talk to people from all across the country. And I feel very lucky that I was asked to do this. So I am going to start sharing a screen, and this will just take a little gymnastics as I get it in the right presentation. And then I need to do a little, screen switch here. But I'm hoping what you're seeing now is a big slide that has my name on it. Is that happening or
Not
not yet?
happening. Not
Okay,
yet.
let's try again. You gave me the power, so usually that works really well. Try this. Are you seeing anything yet?
We're seeing your screen now, yes.
Your screen.
Perfect. So let me make this prettier. And are you seeing my talk now?
Yes.
Great.
Yes.
Thank you for
Perfect.
your patience,
No
everyone. It
problem.
never, it's always something new. So I'm very happy and sad to be speaking about this topic. I think it's a topic that I feel really strongly we should be talking about and to make sure people understand what's actually happening. And it's so different from state to state. I've heard people say they're in Washington, in Nevada, I'm in Wisconsin. And in those three states, the climate surrounding access to abortion, even when you're very ill with a pregnancy related issue, is drastically different. So everything I say today may not be applicable to where you live, but I assure you it is it's affecting someone you know and someone you love. I'm a GYN oncologist by training, which means I take care of women who have gynecologic cancers, such as ovarian, cervical, uterine cancer. To reach that path, I did train as an OBGYN, and I was an abortion provider during my training and immediately thereafter. I have not provided abortion outside of cancer care, meaning sometimes cancer and pregnancy intersect in a number of years. So I think it's important to acknowledge that. And I also think it might be helpful for you to understand how I became someone who gives this talk a lot. And that is because I was the interim chair of our Department of Obstetrics and Gynecology for about 9 months during 2022. And during that time frame is when the Dobbs decision was released and when abortion became illegal in the state of Wisconsin. When I agreed to be interim chair, I had no idea that that was going to happen. It was before the Politico leak, and I, like many, were in denial. So it really shaped a large part of that time. And I learned a great deal from colleagues and experts in legal spaces, from OBGYNs practicing in rural spaces without legal support, and then watching the women in my state be uniquely affected to a really fast change in what they could and couldn't access. So what we'll be talking about today, I'm going to use my state as a case example. I think Wisconsin is a very, I think it's fair to say, tumultuous state politically, and we never know exactly if it's going to be controlled, Republican controlled or Democrat controlled. It's very common for us. We have a very left-leaning senator and a very conservative senator. Right now we have a governor who's a Democrat, but a very Republican state legislature. So it's a very mixed bag. So I will use my state as a case example, but recognizing it's very different as we move through regions of the US. And we'll talk about what does this mean? What does it actually meant in my state for abortion to no longer be legal? And then what happens when a patient is unhealthy, has cancer? In my life, that is something that happens. And we see more cancer diagnoses intersect with pregnancies because we're reproducing when we're older. And the older we are when we have kiddos, the more challenging health issues are going to intersect with pregnancy. So what do you do when there's kidney failure in a pregnant woman and her pregnancy is actually making her need dialysis? Is it okay to terminate a pregnancy in those conditions? If they have a terrible blood pressure disorder that's unique to pregnancy and it's no longer safe to be pregnant, what do we do in those spaces? So we'll talk about that. I do have some conflicts of interest where I serve on advisory boards that are not relevant to this talk. And I want to hold space. I think it is normal and expected to be walking in a quagmire of mixed emotions as we talk about abortion. It brings up a variety of feelings in basically all humans. And I want to go into this talk saying I don't expect or presume that people feel the same way as I do about this topic. I'm really trying to present my experience and the experience of my patients. And I will try and do this objectively and use data. You will quickly, I also wear my heart on my sleeve. I'm an expressive person. You're going to probably guess how I feel about this, but it does not mean I do not respect, care, or honor opposing viewpoints. In fact, I think they're important. This is not an easy topic, and it is not one size fits all. So I will talk a little bit just about what our life was like before Dobbs. So this is post Roe versus Wade, when abortion became federally protected, and pre-Dobbs, and kind of what did the landscape look like in our country? About 1 in 5 pregnancies ended in abortion in our country in 2019, and most of those were in patients who were poor or low income. So income really at the federal poverty level or up to 2 times above it. For those unfamiliar, the poverty level is actually exceptionally little money, and it is incredibly challenging. Living at the federal poverty line is very difficult to do things like pay rent in any major city or feed more than one human being more than Frito-Lays. So these are patients who really do have limited resources. At 2019 abortion rates, it would be expected that about 1 in 4 women will have an abortion by the age of 45. So an incredibly common procedure. The Guttmacher Institute has really accurate and objective abortion statistics, and I recommend that website as a resource. Right now, we know that abortion providers continue to decrease, and that's not terribly surprising, given all the legal ramifications that are needed, that are imposed on people providing that service. So overall, abortion has become stricter in where it's performed. So you can see that it used to be really common, for example, for abortions to be in the 80s to be done in physicians' offices. It's not in the most cases, it's a fairly simple outpatient procedure. And that's become a really small piece of the pie now. So it's also really much less common for them to be done in hospitals, even in patients who are quite sick. So we're seeing the landscape change, and overall, we expect this number to continue to go down. I'll speak a bit about my state because I'll be honest, abortion in Wisconsin was challenging even before Dobbs. So about 6,000 women in my state receive abortions every year, and that's 2020 is the last year we have data available. And the average person who obtains an abortion in Wisconsin is in their 20s and is early in their pregnancy within the first 8 weeks. Black Wisconsinites seek abortions at higher rates than whites. We don't know exactly why this is, but I would assume there are many factors at play, including structural racism, lack of insurance, challenges to obtaining healthcare, and some medical problems that make pregnancy less safe and are more common in Black patients in my state. What was really hard for me to understand post-Dobbs is that for so many women in my state, it didn't matter actually that abortion had been legal for decades because it was so difficult for them to safely access the service. So although we, and I'm like the larger we, were up in arms when the Dobbs decision was made in 2022, really it had been a post-Dobbs world, practically speaking, for so many women in my state. And that was a very important point for me to understand. And it was only through a number of conversations through women living in rural areas with limited means did I understand that even though abortion was legal, it was not at all accessible. So when I say hostile, what I'm really describing is you'll see a map coming up, but long distances needed to drive to get to an abortion clinic, Medicaid or state Medicaid insurance not paying for abortion services, the very challenging restrictions surrounding abortion consent in my state. So it's 2 visits, an ultrasound's required. There are very specific stipulations that the same physician has to see you more than once that make it they're making it intentionally very difficult. So it can be 2 days off of work, even though, again, it's a simple outpatient procedure. It can be hundreds of miles and a gas tank full of gas. And things like childcare, days missed of work can be downright impossible. So for patients who are facing structural oppression and financial scarcity, abortion being legal or not may not actually matter in terms of their ability to access it. And this is in 2020, so this is pre-Dobbs, looking at states that are either very hostile or hostile to abortion. And some of those, so I just named some of the metrics they would look at. And you can see Wisconsin is an orange. And a lot of these states that are the orange and redder hues are now states where abortion access is very, very limited. So I have said this already. And then the average cost of abortion in my state is about $400. 37% of people in our country cannot afford an unexpected $400 expense. So that's an incredibly large part of our friends and neighbors. Since Wisconsin's 2010 election, an array of new abortion restrictions led to the closure of 40% of the state's abortion clinics. So that was an election where our state legislature became very conservative. And there was a huge wave of legislation opposing abortion that was introduced in the subsequent years. And because of all those restrictions, now there is access in the northeast quadrant of the state that is now gone. Really, we're down to Madison and Milwaukee. So there's a huge swath, and those are in the southern, I don't expect you all to be experts in Midwestern geography, but those are in the southern quarter of the state, and and that is the most populous part of our state, but there are huge swaths, hundreds and hundreds of miles of places with absolutely no access. We're talking 4, 5, 6-hour drives to even get to a clinic. So CORE, which is a UW-Madison based reproductive equity collaborative who does research, we do know that birth rates are increasing in counties and now throughout our state where access has been lost to abortion care. That same research collaborative for reproductive equity at our university talked to physicians about their attitudes on abortion. What was really interesting is what most physicians feel is actually really different from how we think other physicians feel. So more than 900 physicians answered this survey, and this is family physicians, OB-GYNs, surgeons, radiologists, pathologists, a whole breadth of specialties. And there was very high support for unrestricted access to abortion. 9 in 10 felt that women's health in Wisconsin would get worse if Roe were overturned. This held true. It was not specific to gender. Both people who identified as male and female displayed these sentiments. Age didn't matter, and socio-demographic factors didn't matter. So there was definitely a quadrant of physicians, about 13% who did oppose, but the vast majority supported it. And I think that is related to what people see as they go through medical training and what I have seen, which is that sometimes pregnancy is very unsafe. And that can be emotionally, that can be physically, it can often be both. But having no access to it can have huge detriment to health outcomes. So what happened? In June 24, 2022, the Dobbs decision was released saying the U.S. Constitution does not confer a right to abortion, and authority to regulate abortion is returned to the states. So for many states like mine, it meant that a law that had been on the books since 1849 now became our acting legal principle for how we decided if abortion was legal or not. So 1849, let's think about this. There's no electricity. There are no antibiotics. There's no chemotherapy, radiation, all modern cancer treatments don't exist. No ultrasound. There's really very little that we understand about modern medicine that existed back then. So now we have a law written from that time that's telling us what we can do to willfully end a pregnancy as physicians. And this is what that law said. It is a felony for any person other than the mother to intentionally destroy the life of an unborn child. perform an abortion except where it is performed by a physician to save the life of the mother. So there's so many problems with this because actually unborn child, when does that start? Is that conception? Conception's actually not really a medical term. It's actually something that's very challenging to pinpoint. So it's very challenging to take this and understand what it means and save the life. Okay, I understand conceptually where they're going for that, but like how close to dead does the woman need to be to save her life? We're not talking about parameters like intubation or pressors or other interventions that are typically utilized in an ICU setting. We have no idea what they didn't know about any of those things. So really a very challenging thing to interpret with modern medical knowledge. So the mother who seeks or obtains an abortion cannot be criminally charged. That was specifically stated in the 1849 law, which is very, very helpful for women because certainly in other states, there are laws that do allow for criminal prosecution of the patients seeking an abortion. It has been, I think, blessing in our state that has not been the case for our patients. So we knew there were some things legally that we could figure out pretty quickly. That if a patient went out of state for abortion, it was still okay for us at UW Hospital to manage and treat any complications they may have from something done elsewhere. We were pretty quick to figure out that ectopic pregnancies, which are pregnancies that implant in the fallopian tube instead of the uterus. So these are medical emergencies. These patients, before we were able to detect and do a fairly straightforward surgery, or in certain cases, give medication. These are women that almost uniformly bled to death. It was terrible. Ectopic pregnancies can't result in a live-born child. Although people have said you can move that pregnancy into the uterus, that's actually never been done. I believe a politician made that claim, and it's just not scientifically, we're not there yet. So because an ectopic pregnancy cannot result in a live-born child, it was felt that did not fall under the umbrella of this law, nor did contraception. So we knew that there were some spaces where we were still okay. But we did not know what we were going to do when a woman came in with a pregnancy-related complication that was absolutely threatening her life, where an abortion would fix it. What were we going to do in a woman who came in 18 weeks pregnant, right? Very, very far from what we call viability. You cannot deliver a baby that will survive at that age. But what if they come in hemorrhaging? What if they have a placental abnormality and are not able to continue the pregnancy safely? How much bleeding needs to happen for me to say I'm saving their life? How do we document that? What metrics are they looking for? What metrics would a lawyer look for or a criminal prosecutor look for to make sure I waited until they were sick enough to intervene? And then what are the implications of that morally and ethically, that I could help a patient sooner, but feel legally constrained to do so? So all of these things, this was so many meetings and legal consultations and trying to understand a new normal where procedures that we did routinely in our hospital in life-threatening circumstances really could not be done anymore without very careful legal support and meticulous documentation. Ultimately, we decided that 3 separate physicians had to attest that an abortion being done was in fact a life-saving procedure. The amount of time and moral distress this took was frustrating, to say the least, and adding all these layers of complexity to patient care that's already really nuanced and really difficult. And these situations are never fun. Most of these pregnancies are wanted pregnancies. And then people come in with these really terrible pregnancy-related complications and have to make terrible decisions. And now we have to say, wait, not only do you have to make this terrible decision, I have to now make sure it's okay. It's legal for me to do this. So layered. So we knew that we could refer patients. So what we've learned is that we can still, in our current climate, refer patients to Illinois, Minnesota, Michigan, and all of those states have seen a huge uptick in the number of abortions performed. And you can imagine Illinois is kind of basically surrounded by states with very limited abortion access. They have a huge influx of patients. So the number of abortions in that state alone has increased 70% since Dobbs, more than 80% in some other states like Colorado. So we can legally refer, but it's not necessarily, now we have a longer distance for our patients to drive, perhaps more obstacles for them to even get there, and long wait times. So patients are getting less safe procedures because they're at more advanced gestational age. I will say that our law, at the time that the 1849 law was written, medical abortion, so abortion pills were not a thing, but the language there did not stipulate that medical abortions would be okay. So those were also became illegal in our state at that time. And that's about half of abortions in the United States. So clinicians who provide the medication abortion have to be physically present with the patient. So we couldn't like use an Illinois provider to get our patients medications. And while mail order medical abortions are available, it's typically prescribed by MDs who live in other countries and who are assuming they won't be extradited or face felony charges should that prescription be traced. So it's not a totally legal workaround. So we talked about this. We knew that abortion would still be okay to save the life of the patient, but that was really, really difficult to do in clinical contexts where the patient's life was in jeopardy. So in OB, I have to say that obstetrics, things happen very fast. And what's so hard is that it's often young, healthy patients who are pregnant and come in with these really unexpected complications. Their water breaks, again, 17 weeks, so far from the time we would expect a viable birth to occur. Now, that in and of itself is not immediately dangerous, but once your water breaks, you lose a barrier between the outside world and the uterus. And the rate of infection, an intrauterine infection, is pretty high. Not 100%, but it's pretty high. And that can be incredibly deadly. And this is actually why abortion is now legal in Ireland and other countries, is because they had patients like that who their water broke. They requested an abortion because they knew they could get very sick, and it was denied because they weren't yet sick. And then those patients got incredibly sick very quickly, and it was too late. They couldn't be saved. So it's really difficult because patients, young, healthy patients, tend to be totally fine. Totally, their vitals are good. They don't look like they have an infection. They're walking around, and then they crump. And we were not able to consistently identify or act in that narrow space consistently. And that's how women died. And that's one of the reasons abortion has become illegal in Mexico and Ireland and Hungary, other places. So I will mention other restrictions. So there have been other things, and I know you've all heard about this in the news, is that in Alabama recently, the Alabama Supreme Court issued a ruling declaring that embryos created through in vitro fertilization, so intended to be used to help a couple, or not a couple, any human be pregnant, carry a pregnancy, should be considered children. So that caused a whole lot of problems, and IVF basically stopped because part of what happens if you're implanting an embryo into the uterus is it doesn't always work. And sometimes embryos are abnormal or need to be destroyed. And if sometimes you drop a petri dish, and if all of that's considered a child, then that opens up a legal quagmire. Quickly, the Alabama governor signed a law to protect IVF treatments. That happened pretty quickly the following month. And they did resume because that bill included criminal immunity to the physicians and healthcare providers working in IVF clinics. But the enacted legislation doesn't define really whether under state law, frozen embryos created with IVF would have the same rights as children. Like, do you have to pay child support for an embryo? This is going to be a long battle, and we're going to see this again, and we're going to see this in other states also. There have been certain religious organizations that have come up publicly against IVF, and it's really unclear to me how safe that procedure, access to that procedure will be in states that have abortion restriction. So I am happy to report that in our world in Wisconsin, a circuit judge recently decided the 1849 law was not meant to describe elective abortion, that it really was written in the spirit of protecting women from feticide. So women who were being abused or assaulted, and when harm came to that pregnancy, that felony charges could be incurred on the person who harmed the fetus. So we now do have access in our state. That can change with any election. We have an state elected Supreme Court, and the makeup of that is very narrowly right now in favor of what are considered liberal justices, more liberal justices. If that changes, I fully expect us to see another version of the 1849 law or something more restrictive come back into play. Another issue, though, that we had to deal with during the almost 2 years where Dobbs was enacted in our state was very applicable in my world, which is the health of the patient. So we sort of understood what we could do to save the life of a patient and how we could maybe document that and how we could maybe legally protect the physicians facing criminal charges if it was found that they were not in fact saving the life of the mother. So I think that's an important point that I actually haven't made yet is, malpractice insurance is important, right? It protects physicians who are also humans and may have complications related to practicing with good intent. So hospitals typically cover physicians, their malpractice insurance. So if someone brings a suit, you can expect some legal support in that space. Definitely is not the case for a criminal charge, right? If I'm charged with a felony because I did an abortion, the hospital is not going to find me a lawyer and pay my legal bills. That is totally different space, really unprecedented space. And so our physicians and other providers were terrified, right? Because even if they knew they were acting with the most sincere intent to save the life of a patient, if even the criminal charges themselves, even if they were eventually found innocent, the legal costs of that can be devastating. So it really, in many states, remains very scary to have potential felony charges surrounding to what was really routine medical care. So in my world, it's not necessarily about saving the life of the patient, but potentially more focused on the health of the patient. So we'll talk about cancer and pregnancy briefly, because this happens. Breast cancer, cervical cancer, ovarian cancer. So cervical and ovarian I treat. Those are very common in reproductive aged women, and we're seeing more and more. There are other cancers listed there that are common in pregnancy also. And really what we can do to treat cancer in pregnancy is very limited. I made a little list. So on the left side, there's some chemotherapy, not all, that's okay. Some surgeries can be done safely in pregnancy. Mammograms, MRIs, so some of the imaging studies we really like to use to understand cancer and where it's located. You can do those things, but if you're pregnant, there are a lot of things you can't do. You can't do laparoscopic surgery or the more advanced surgery with small incisions in the abdomen if a patient's quite pregnant. CT scans, PET scans, radiation therapy, lots of chemotherapies, immunotherapies, really not tested or known to be unsafe in pregnancy. So when you're working in a space where you can only do an abortion to save the life of the mother, but you can't totally treat their cancer correctly, where are we living in then? And I'll just share an example from my practice from 2023. A 30-year-old patient came for her first prenatal visit, saw one of my OBGYN colleagues who did a speculum exam to look at the vagina and the cervix, and they saw an abnormal lesion, not super big, the size of a big grape, but they took a biopsy of this lesion on the cervix, and it was a cervical cancer. The black arrow points to, this is the uterus here. I don't know if you can see my arrow, but the black arrow points to the tumor. You might get a flavor that that's pretty small. It was, and we were able to do this safely, an MRI safely, totally fine with pregnancy. And this was an early pregnancy, so you're not going to see a whole ton of pregnant detail here. And we were able to do the standard of care procedure to assess her lymph nodes because she was so early in pregnancy, we could do a laparoscopic procedure. So that is good news. She was eventually found to have an early stage cervical cancer, but in general, which is very curable situation. In general, the preferred treatment for that is what we call a radical hysterectomy, which is taking out the uterus, cervix, and some of the connective tissue surrounding it, or a trachelectomy, which preserves the uterine cavity, but still ends the pregnancy. So was this life-saving? And I made an argument it was, but that was not, our lawyers did not agree with my assessment. They said you can delay her care. It's okay. This patient will not die during her pregnancy of cervical cancer. And that probably was true. But was I serving her to my best ability as a cancer treating physician? I didn't feel I was. She ultimately chose to go out of state and then return for her cancer care after she had an abortion legally. But it's really difficult to know what would have happened if she carried the pregnancy and sought delayed care for her cancer. And we can do, like I said, we could have done some chemotherapy while she was pregnant. and then deferred her definitive or curative treatment until after pregnancy. But I don't know if she would have been the same stage or have those same options available. So I mentioned what happened to her, and she is doing well. But it was very, again, I wanted pregnancy, very emotionally challenging. And in the end, she said, I have 3 other kids or 2 other kids. She had other kids. She had other kids. You know, she's like, I need to be here. And I understood that. So what we also don't know is really a lot of cancer outcomes in pregnancy. So we don't have enough data about women who are pregnant, who continue their pregnancy, and then perhaps have suboptimal or delayed care. We do know for melanoma and breast cancer that we see those HRs are called hazard ratios. So we see higher hazard ratios are more likely to have disease-specific death compared with non-pregnant patients. So 1.5 times more likely to die of a cancer-related cause if they were pregnant when they were diagnosed. And in certain cancers that are pretty common, again, not super common, but common enough that you will see this happen. If you're a medical oncologist, you're going to see this happen once or twice a year. The most common type of leukemia, acute myeloid leukemia, when diagnosed in the first trimester, if you delay treatment, that is an incredibly fast growing cancer. And we know that patients who delay treatment do not do as well, and many of them die. It's kind of one of those, as soon as you find it, you have to start treatment within 3 or 4 days. So actually a society recommendation is to consider pregnancy termination if that happens in pregnancy, because it's so clear that outcomes will change for the patient. So we don't have enough data, but I know that we need to be considering this a little bit differently, because when we again have this intersection of pregnancy and cancer, we need to be able to give a patient all of their options and allow them to make the right choice to prioritize their health, their pregnancy, whatever feels right to them and their family. So when standard medical care is criminalized, which is essentially what I've been describing, we've seen delays in care, division among physicians, worse distress for our patients. And it's worth mentioning wasted time and effort in an already taxed system. I don't know how many of you have tried to make a doctor's appointment in the last 6 months, but I'm guessing you weren't able to get in right away, or you tried to schedule a colonoscopy and they said, sure, we'll see you in 2025. Healthcare is not having its best moment right now. There are staffing issues. There are so many patients are underinsured and can't get the care that we want them to be able to access. There are so many hoops to jump through just to get good primary care. And the more time we have to spend thinking about what is legal, acceptable, morally justified, the less time we can spend actually thinking about what that patient needs and how to best deliver it. I will also just mention this specific to my state. We know this, that prohibiting abortion does not remove the need for abortion. It instead exacerbates the economic stratification between those who can and cannot access care. We talk a lot about health equity. That has been a huge and really important topic of conversation. I bet HealthAdvocateX and others have done talks specifically on this. And in my state, I know that Black women are more than 3 times more likely to die from a pregnancy-related cause than white women are. So how do we correct for that when abortion is illegal for everyone? How do I say you have to shoulder that risk? You have kidney disease. You have poorly controlled diabetes. You are more likely to need dialysis if you continue this pregnancy. How do we meter that? And how can we talk about care for everyone when outcomes are so inequitable? The American College of Obstetricians and Gynecologists state that safe legal abortion is a necessary component of comprehensive health care. And this is important because this means the ACGME, which governs OBGYN residencies, has to decide if abortion training is required to be an obstetrician and gynecologist. And it is. Residents must be involved in the management of the complications of abortions and have clinical experience or access to experience of the provision of abortions. Now, of course, if someone morally does not want to participate, that is okay. Opt out is always okay. But ACGME updated this after Dobbs, saying even if the residency program is in a jurisdiction where abortion is restricted, you have to provide that training. So they've doubled down, saying this is a critical part of being a physician who takes care of women who are pregnant. And we are not going to take that requirement away. So I'm going to end the talk there. So much was covered. This is a summary slide that I won't read out loud because it just summarizes some of the key points I've made. I know that I really touched on a lot of different things that probably brought up a variety of emotions. And I really would welcome a robust conversation, questions, anything you want to unpack a little bit more. Thanks for your attention. I'm going to stop. Oh, sharing my screen. I think I did a terrible job of that. I will try again.
Okay. Thank you very much, Lisa. That was a wonderful talk. It's a very complicated issue, as your talk actually shows and details quite a bit. Yeah, I mean, the thing I find is that there's definitely not enough research and education, or not education, but knowledge based on what this can actually do for women and what it ends up being in terms of theirs. But it also kind of just shows the complications that doctors get into by trying to figure out, is this legal, is this not, when in fact, young, healthy people, like you said, tend to turn very quickly in terms of being healthy, and then all of a sudden are crumping, as you mentioned, and it's hard. So I will open up the questions. If you have any questions, please raise your hand or type them in the chat, and I'd be happy to get them if anybody does. I know Anne had a question about the upcoming elections with states putting abortions on the ballot. Can this decision be overturned? Yes, it could. It'll have to go through the same exact process that Dobbs went to, all the way up to the Supreme Court, most likely. But that's my best. None of us are lawyers, or at least I'm not a lawyer, and Lisa, I know you're not a lawyer, so.
No, I will say that right now, I think this is really, I think in the short term, we should expect this to be an issue controlled by states. And there are states that have chosen to make this constitutionally protected in their state. Not every state changes their constitution via election, but there are other ways to get propositions on a ballot. And certainly many states are introducing legislation surrounding this. And a lot of people are voting to protect access to abortion, even in places where we wouldn't necessarily expect that, like Kansas.
Yeah, Lisa, this is Anne. I wrote the question, and that's what I meant by that question. Can the states, because we have it on our ballot in Florida, and we're our governor is pretty strong about it, but it is on the ballot for November. So if it passes in November on our ballot, does that mean that the law reverses?
Yeah,
Just
so right
in our state,
in your state. Yeah, in your state right now, state control is the federal law says states figure it out. So if your state introduces legislation that is passed via a statewide election, that is what your state will be doing. Now, if the federal law then changes again at some point,
that would
we could have
it's
a whole other circus, but that's years away.
Right. Okay, thank you.
There's a very smart law student who just made a comment in the chat. Thank you for that.
Yes. And then there's another question. How many states are losing OBGYN providers because of restrictions?
That's a great question. Idaho is the state where the most has been published and has actually reached the mainstream press. They've lost about 30% of OBGYN providers in that state, which already had too few. It's hard to track that because there's many reasons people move. So unless a person is willing to self-report and really reach out to media, to their exit interview in a hospital system, or really make it known that that was part of the reason for leaving, we may not be able to capture that data accurately. So the data we've been able to capture a little bit better that I think speaks to this is what's happening with medical students and what's happening with OB-GYN residents. And what is happening with medical students is twofold. One, fewer are choosing to go into OB-GYN, and that is the last thing that the uterus containing humans of our country need, as fewer people committed to this specialty. And that two, fewer medical schools in states with abortion restriction are getting fewer applicants. It's not like crazy, but it's noticeable and it's real and it's trackable post-Dobbs. The other is we, like many residency programs, we have a survey that people interviewing here for residency complete after they come to interview. And one of the questions we have chosen to ask is, does legal abortion access factor in where you will choose to train? And the huge majority say yes. And the huge majority indicate that they want to train in a state where they will have access to abortion training legally.
Well,
so one could infer they may choose to practice in that environment as well.
I mean, I think it's also one of these things where as a student, you want to learn everything possible to treat your patients. And, the old adage in medicine, which I'm sure that you still use, is see one, do one, teach one. But you really need to understand what the procedure is, what the risks and things, because even if someone does one illegally, they're still going to come in and you have to know how to treat them. And unless you've seen them enough, you're not going to be of any help really to them. Rebecca also had a question on how these decision laws are affecting medical education for the physicians. And I assume what you just said answers most of that, unless Rebecca, you have another.
I would make one more small point surrounding that, is that it's really now the residency programs in states with restricted access now are often having to fly their residents elsewhere for abortion training, put them up for a month. For a period of time, that's what our residents were doing is, and they still actually are because they're getting great training, but they're going to a residency program in Chicago, and we pay for them to stay in an apartment in downtown Chicago. I mean, this is, people running residency programs are not flush. So this is a huge, huge expense. And also residency is hard. So spending a month or two away from your family is a huge ask. In order to get what's pretty routine and should be widely available training.
Lisa, I have a question. When you were talking, as advocates, we're always trying to put patients first, right? Patient-centric. And when you were talking about the example of the lawsuit, or when you spoke to the lawyers and they basically said that, the woman with cancer, that, she needed to, basically carry to term. Like, is it that they consider the fetus a patient and they are putting it at the same level as the mother with cancer? Or is it just because we now have, basically politics running this decision?
Yeah.
I'm just curious, your opinion.
So it does look different state to state. So there are states where the laws are very fetus centric and actually promote rights, like human rights for the fetus. Texas is an example of that. Alabama with this IVF is an example of that space. A more common restrictive legislation just says abortion is illegal and puts that in, and it doesn't give exception, right? So it's not really trying to get into the nuances of we prioritize the specific health of the fetus over the mother. That is the sentiment behind it, but the legislation doesn't typically say that, because the reality is, depending on where you are, it might be that I can give chemotherapy, and if that chemotherapy hurts the fetus, that's not illegal, which is crazy. And you would, and again, that's not the path you would typically choose, but that is an example. These decisions, I think you really, Beth, just underscored the point. These decisions are so hard. Like, I've been training for decades, and I find medically these are really challenging spaces to be in. And these patients are making these horrific decisions that they never wanted to have to make.
Right.
And then we have people without medical backgrounds who are writing these laws.
Right.
It's a disconnect, and it's a really tough one.
And we encourage patients to be in charge of their decision making, and they're not in charge of this, basically. So it's just kind of baffling to me. Thank you.
Mm-hmm.
And then Anne is asking if there were any safeguards put in with the Dobbs decision for educating women about preventing pregnancies, childcare for mothers, or and adoption options. And from my reading of it, there aren't. But I'll see if you have any other thoughts.
No, none that I know of. And if that I'm sorry, I forgot your name, Kendra, law student, knows of any, I can't think of any protections. And that's actually been hard, is that many of the states with abortion restrictions actually tend to not have, for example, extended postpartum Medicaid coverage for moms and babies, or liberal parental leave policies in place, or even free lunch programs. Things that can make it a little bit easier to actually raise the child safely in a healthy environment. There's been a bit of a disconnect there.
Let's see, Melina has a question here. I'm just reading through it first.
Thank you, Melina.
Oh.
I look forward to looking at that link.
So, are there any other questions that we could offer? Oh,
I'm just curious if for you, how do you move forward and feel comfortable with providing care when all these restrictions are in place and your patients might be asking for things that you can't provide? That has to be so challenging personally and professionally.
And, I think honestly, the hardest part of when I was a chair, right? Because I felt so uniquely responsible for the health, and I still care so much, but you feel so responsible for the health and well-being of the women who are receiving care by the physicians in your department. And I was so focused on the patients that it wasn't until really after I wasn't the chair anymore that I saw the toll it took on the faculty. And I knew I was feeling it personally, but I just saw the overwhelming burden for people who really, again, they just want to do the right thing for the patient. That is truly their North Star. And to feel yanked from that is really distressing.
Margaret, you had a question?
Yes. So many comments and questions. So it's hard to take a breath, take a moment and go through it. So the population I primarily work with for patient advocacy is rare genetic connective tissue disorders. So then I can see you nodding, so you know where I'm going. So, and in this population, there's a lot of issues with getting pregnant and staying pregnant.
Yes.
So there's other things like incomplete miscarriages, which then need an abortion to complete it, which gets very complicated because then you have a very sick individual who then has to go to in real time. This is what we're seeing. Go to another state to get care in that way, because the people making the rules and imposing these restrictions are the people who don't live with a uterus, don't live with health complications, and don't understand the ramifications of what they're doing. So I know it's a long shot, but Congress could pass legislation that permits abortion, right?
Yes, I would put that in the long shot category.
Yeah, very long shot. And when people are talking about cancer, it's easy for them to relate the concept of, oh yes, the woman's or the person with the uterus, their health is at risk, so we need to pursue this. And I know that your specialty is cancer. In your practice or in your hospital, do you see these other situations with chronic conditions?
Absolutely. So you're right. I did speak to the health issue that I see the most and know the most about. But I mean, I can picture the women's faces. Like, we definitely have had two patients with pulmonary hypertension who pregnancy is unbelievably risky, like a 30 to 50% mortality rate, right? Like terrible statistics, who had to go out of state to end pregnancies. A patient who had anencephaly, which we didn't even talk about this, a fetal anomaly, not compatible with life. It's basically where the skull and the brain don't develop. I mean, that is not going to result in a fetus. Many of them die in utero, but many of them are term and then die several days after birth. And there was nothing in that law, in the 1849 law, that talked about that. So these women who couldn't go out of state had to carry these babies to term, knowing they were going to die. We see patients with connective tissue disorders who've had vertebral artery dissections, like very terrible types of strokes. You're obviously very familiar, but for those who aren't, and that, those vascular events are much riskier when you're pregnant. So you bring up the good point that we've done such a kind of bad job defining this scientifically, that there's pregnancies that are ending, right? Like that's just what's happening. That whoever's in charge has decided that this pregnancy is not embedded correctly. The heart rate is slow. You can clearly see it is not going to result in a live-born child, but we have to wait until there's no heartbeat in certain states. And that delay in that time is emotionally terrible for many patients, but also can put other health issues. It can elevate them into higher risk categories where they don't need to be. Yeah, thank you for elevating. You're right, cancer was what I talked about, but there's so many examples of other health conditions where this can be equally or more problematic.
Well, I think this also shows just that laws don't know what the science is, because we really haven't been able to define where life begins as a human. I mean, back in 1849 with your law that was done by the quickening, if I remember right,
That's right.
Which was the first sensation of of the pregnancy, and that's several weeks, if not
Usually
down
months.
that way.
Yeah.
But also, I mean, what makes this different in terms of human versus animal, and it really is with the anencephaly, I think, is the brain activity and all of that. So, but the laws are always kind of are not quite on the same page. So, Heidi, you have a question.
I do. Thank you very much for this really interesting talk, and really a terribly difficult situation that I think women are in this country. In any event, so you mentioned that, of course, the rate of abortions in hospitals has gone way down. Now, although they didn't really decide on it and pushed it back to the Ninth Circuit, the EMTALA decision or non-decision that just came down upholds EMTALA, right? So sending women to ERs where the ER physicians are mandated to make sure that, sorry, urban landscape here. Where the ER physicians are mandated to make sure that the patients are evaluated and stabilized or treated as necessary. Is that an option?
It is a little bit helpful, I will say that. But the issue is the ER physicians, and they're amazing. I think ER physicians hung the moon because they can deal with so many different things. But I do not know one ER physician who can perform a pregnancy termination beyond very early weeks, right? Like that's a pretty nuanced skill. So they can stabilize, but there's still going to have to still be a phone call, right? The OB-GYN team is almost universally going to have to be involved. And EMTALA the protections aren't so fantastic for the person actually providing the abortion. And in the states where it's very, very restricted and it's a criminal charge, EMTALA has not provided enough pinpoint guidance to protect against state legislature. Like, because you can almost always get someone on a helicopter, and this is happening. Someone talked about Idaho and Washington. This is happening all the time. They will stabilize them to get them on a helicopter to get them to Washington State. Like they will do that, but that is legally the less risky thing than actually doing the right thing for the patient in that facility. And that really is hard. It's really hard. to know that you can help somebody, but you can't.
Thank you.
And I think also just the extra financial expenses too. You look at that.
Oh,
I mean,
it's last thing our healthcare system
I mean,
needs.
with it being running behind already, I mean, the last thing you need to do is, get life flight, get all that stuff involved.
Yeah.
It's just horrible. So. Well, thank you very much, Lisa, for this wonderful talk. I think we will end it
Yeah,
here.
great. Thank you.
Thank
we
you.